more people may trickle in while we're doing some introductions, but we really want to thank everyone for being here. This is the March version of the Journal of Vascular Surgery online journal club. Again, the format is we will have 2 articles that we'll be discussing tonight. The first is the effect of concomitant deep venous reflux on truncal endovenous ablation outcomes in the VQI. And the second is on fast track thrombolysis protocol, a single session approach for acute iliofemoral deep venous thrombosis. Our 2 host organizations this evening are the Carolinas Medical Center and the Maine Medical Center. And our specific faculty and residents are here. Dr. Charlie Briggs is a vascular surgeon at Atrium Health in the Carolinas Medical Center. And his first-year fellow, Dr. Parikh, will be presenting, as well as from Maine Medical Center, Dr. Anna Bonikowski, who is the Medical Student Clerkship Director and a new faculty in Maine, and their first-year integrated resident, Dr. Menisandran. We have 2 special guests, which are always fun to help us with commentary and questions. That's Dr. Anil Hirani and Dr. Ruth Bush. And even more exciting is we have some of the authors from the paper, specifically from Michigan. Dr. Craig Brown, I saw, is on the call. Dr. Nicholas Osborne, Dr. Peter Hinke, and then of course, Dr. Wakefield is here with us this evening as well. Just a couple of specific things. Please keep your microphone muted. If you have questions or comments, please put them in the chat. We'll go through and ask those. And at some point, if we have time, we'll even ask you to unmute your microphone and speak if we can. The event is being recorded for on-demand access. And our next online journal club will be in April. It's April 14th at 8 p.m. Eastern. It's usually advertised through social media on the JVS website and the SVS website. And that will be hosted by Mount Sinai Medical Center, Dr. Daniel Hahn, and then of course, University of Buffalo, Dr. Linda Harris. So with that, I will stop sharing my screen and we will have the first article brought up and our first faculty begin.
Thank you very much. This is Charles Briggs from Carolinas Medical Center. I'm the Associate Program Director of the Vascular Surgery Fellowship. The paper that we will be presenting this evening is out of the Journal of Vascular Surgery, Venous and Lymphatic Disorders. This is entitled Fast Track Thrombolysis Protocol, a single session approach for the treatment of acute iliofemoral deep venous thrombosis. This article is out of the NYU Langone Medical Center and Brooklyn Hospital and is authored by Enrico Asher and his team, including Dr. Hingarani and Dr. Kibrick. I find this article to be particularly timely as March is Blood Clot Awareness Month. So please spend some time this month directing energies toward the prevention and treatment of blood clots. Acute thrombosis of the deep veins of the legs remains one of the most significant public health problems in the United States, typically responsible for more than 350,000 people diagnosed annually and is responsible for between 100,000 and 300,000 deaths. This is to a tune of 7.5 to 39 billion in 2010 US dollars. It was such a crisis that in 2008, the Surgeon General released a call to action that prompted the 8th American College of Chest Physicians Consensus Conference and the American Heart Association to release additional scientific statement on the management of iliofemoral DVT, recommending interventional strategies for thrombus removal, including surgical and catheter-based techniques to reduce the incidence of post-thrombotic syndrome or PTS, especially in patients with extensive venous thrombosis. While those guidelines have been revised over the years, in 2016, for example, the chest physicians recommended at a grade 2C recommendation for anticoagulation alone over catheter-directed thrombolysis, but a subheader did suggest catheter-directed thrombolysis for iliofemoral DVT in good risk patients. And the American Heart Association echoed that guideline as well, recommending catheter-directed thrombolysis or pharmacomechanical thrombectomy as a reasonable first-line treatment in patients with acute iliofemoral DVT to prevent post-thrombotic syndrome in appropriately selected patients. Post-thrombotic syndrome, of course, is a sequelae of typically acute iliofemoral and sometimes secondary DVT that causes venous occlusion, damage to valves, and the associated venous hypertension, all combined with tremendous amount of inflammation of the lower leg, leading to ectasias, telangiectasias, as well as the more severe morbidities of edema, hyperpigmentation, lipodermatosclerosis, and venous ulceration. Iliofemoral DVT and severe symptoms of acute DVT are predictive of post-thrombotic syndrome morbidity when treated with anticoagulation alone. When successful, thrombus removal results in restoration of venous patency, maintenance of valve function, the improvement in quality of life, and the reduction in the risk of recurrence. This significantly reduces the incidence and/or severity of PTS, depending on the study you're looking at. While open venous thrombectomy is rarely contraindicated, typically endovascular thrombectomy is preferred due to the comorbidities of the patient population and the associated morbidity of open venous thrombectomy itself. Catheter-directed thrombolysis and pharmacomechanical-directed thrombectomy have been looked at in two major papers over the last 10 years. The first, published in Lancet in 2012, was entitled the CAVENT study, and this showed a reduction in the incidence of post-thrombotic syndrome at 6 and 24 months, as well as an improvement in iliofemoral venous patency after 6 months in patients treated with catheter-directed thrombolysis as compared to standard catheter-directed thrombolysis plus heparin or anticoagulation as compared to patients treated with the standard therapy of heparin or anticoagulation alone. The second was looked at and it was published in the New England Journal of Medicine in 2017, entitled Pharmacomechanical Catheter-Directed Thrombolysis for Deep Venous Thrombosis, better known as the ATTRACT trial. And this showed a reduction in the severity of post-thrombotic syndrome in patients treated with pharmacomechanical catheter-directed thrombolysis as compared plus anticoagulation as compared to patients treated with anticoagulation alone. Catheter-directed thrombolysis with or without percutaneous mechanical thrombectomy is, of course, not for everyone. There are very real, absolute, and relative contraindications. But in those patients who it is safe to proceed with a low risk of bleeding, there are two additional challenges faced by endovascular thrombus removal, and I categorize those as placing the burden on the interventionalist and placing the burden on the institution. By placing the burden on the interventionalist, I mean that these cases can take quite a while when done in either a single session or can utilize quite a bit of resources to be done in dual or concurrent sessions. These have considerations for the interventionalist, other patients, for the interventionalist partners, and for the interventional suite itself. Second, there are additional financial or institutional burdens, i.e., there's a specific cost of case as related to the cost of thrombotic medications, catheters, and adjunctive devices, of which there are many, and the unfortunate cost of complications ranging from intracranial hemorrhage to GI bleed, hematuria, epistaxis, etc. Finally, there's the associated hospital care. Typically, if patients have a lytic catheter placed, they undergo care in an ICU. They get a series of a battery of lab tests done. And then, of course, there's the care of complications, which can draw in many other service lines as well. That said, I'm confident that the team from NYU Langone Brooklyn Hospital, with their paper, will present us with a very nice alternative to this. And I'll turn the floor over to my first-year fellow, Dr. Rajvi Parikh, to present the article.
Hello, my name is Rajvi Parikh. Thank you so much to Dr. Humphreys and Dr. DeMuzio for organizing the JVS Journal Club and for allowing me the opportunity to present. And thank you, Dr. Briggs, for the introduction on the paper. So as Dr. Briggs has already mentioned, iliofemoral DVT is associated with many short and long-term complications, including post-thrombotic syndrome, and catheter-directed thrombolysis and thrombectomy for iliofemoral DVT is associated with improved outcomes, but does require multiple sessions and prolonged hospital stay, which has the implications of increasing cost and the risk for complications. And so this paper discusses the fast track thrombolysis protocol. This is a novel single session technique with the goal of restoring iliofemoral venous patency during the initial session of thrombolysis to minimize costs and complications associated with prolonged thrombolytic exposure. So this was a single center retrospective analysis of patients undergoing FTTP, the fast track thrombolysis protocol for occlusive iliofemoral DVT from January 2014 to February 2019. The operative data was initially collected as part of a clinical quality improvement initiative, and then statistical analysis was performed using chi-squared and unpaired t-tests. And the postoperative outcomes evaluated were 30-day complications, 30-day rethrombosis, major adverse limb events, PE, intracranial or retroperitoneal hemorrhage, and all-cause mortality. So this was the algorithm that was used by the team at NYU Langone. The diagnosis of iliofemoral DVT was confirmed using clinical exam and duplex ultrasound. The patients were then systemically anticoagulated with unfractionated heparin using a 100 unit per kilogram bolus, followed by a intravenous infusion of unfractionated heparin. And this was continued throughout all procedures. The thrombus was then graded by the operating surgeons by independently reviewing the ultrasounds to either extent 1, 2, or 3, extent 1 being thrombus involving only the external or common iliac vein, extent 2 involving the iliac and femoral veins, and extent 3 with thrombus extension from the iliac to the popliteal vein. And you can see that most patients had extent 1 or extent 2 thrombus. So the initial ultrasound guided venous access was then performed and an 8 French sheath was placed. The patients were then given an additional 100 unit per kilogram bolus along with the continuous infusion of heparin. Contrast venography was performed to assess the extent of the thrombus. And then initial debulking was performed using the rheolytic thrombectomy feature of angiojet to remove any fresh thrombus. And so before 2015, they were using the angiojet Solent, and then after 2015, they were using angiojet Zelanti. After this, then they used the power pulse feature of angiojet to uniformly deliver 10 milligrams of tissue plasminogen activator, TPA, diluted in 100 milligrams of saline directly into the thrombus. Immediately after this, the thrombus burden was macerated with a low pressure balloon using either an Atlas or Conquest balloon to increase the surface area and to expose any potential underlying stenosis, stricture, or fibrosis. And after this, the alteplase was then left in place to dwell for 10 minutes. And then the angiojet catheter was used again to perform rheolytic thrombectomy to further debulk and remove any remaining thrombus. After this step, then repeat balloon venoplasty was performed to assess for any residual stenosis. If greater than 50% stenosis was appreciated, then an appropriately sized self-expanding wall stent was deployed. And if not, then no stent was placed. And then completion venogram was performed to assess for patency of the venous system. And so you can see here, this is the balloon maceration technique. And you can see that it's showing areas of residual stenosis. And then here you can see the stent, the wall stent placement with post-stent placement of venoplasty and then the completion venogram. And then with the completion venogram, if there was no residual thrombus, then the patient was discharged to the floor from the post-anesthesia care unit. If persistent residual thrombus was appreciated, then a lytic catheter was placed and the patient was started on a continuous infusion of TPA at 1 milligram per hour with close monitoring in the ICU and relook at 12-hour intervals until there was angiographic thrombus resolution. Post-procedure, the patients were started on a 6-month course of a factor Xa inhibitor. And then this was either with rivaroxaban or apixaban with the loading dose. And then after that, patients were started on antiplatelet therapy for life. And then follow-up was within 1 week of intervention and then every 3 months thereafter with a physical exam and duplex ultrasound to assess the IVC and the lower extremity venous system. And so these are the results. So in a 5-year evaluation period, there were 38 patients that underwent the FTTP procedure. The median age was 66 years of age and 60.5% were female. As you can see, there was no statistical significance in the distribution of patient comorbidities, the thrombus grade, or thrombus laterality. 50% of patients did present with an unprovoked DVT, followed by 42% of patients that presented with stent thrombosis. The mean procedural time was 122 minutes with a range of 59 to 224 minutes. The most common access sites were the popliteal or femoral vein. 81.5% of patients were successfully able to undergo the single session protocol, with 18.5% of patients requiring 1 or more sessions with overnight lysis. The 30-day rethrombosis rate was 0, and no patients experienced PE, intracranial hemorrhage, or limb loss. The all-cause mortality was 0, and 1 patient did experience a retroperitoneal hemorrhage, which was managed conservatively. The median total TPA dose was 10 milligrams with a range of 4 to 20 milligrams, and the median total heparin dose was 5,000 units with a range of 3,000 to 700 units, or 7,000 units, excuse me. And 79% of patients did undergo placement of a self-expanding stent to restore venous outflow. This facility does not have IVUS, and so could not fully ascertain the cause of luminal narrowing in the iliac vein, but they do discuss in the paper that they would recommend the use of IVUS if it's available at your facility. The median range or post-intervention length of stay was 1 day, and successful thrombus clearance was appreciated in 100% of cases. The limitations of the study is that it was a single center retrospective review with a modest sample size. And there was a lack of prospective and follow-up Villalta scoring, and so this prohibits long-term analysis of PTS incidence in this patient population. The discussion, FTTP in this patient cohort did show a low incidence of bleeding and did use lower volume lytic agents for a finite amount of time under direct visualization with hemodynamic monitoring. The repeat balloon maceration was the major factor associated with technical success of this procedure, as it increases the surface area for TPA to dissolve the thrombus and reveals underlying culprit stenoses. It also maximizes the interaction of the TPA with the target thrombus to make the single session approach feasible for patients with acute iliofemoral DVT. And then the speed of the procedure with short exposure to TPA potentially eliminates the feared and potentially fatal complications of PE and intracranial hemorrhage. And so in conclusion, FTTP appears to be a safe, efficacious, cost-effective approach to restore iliofemoral venous outflow in the presence of acute iliofemoral DVT. It minimizes blood loss, reduces cost, doesn't require general anesthesia, foregoes the need for surgical exposure, and in most cases does not require prolonged TPA infusion.
Thank you, Dr. Parikh. Dr. Hirani, I think you've stirred up some controversy. We have several questions that have come up about your paper already, and I think there are a lot of people that want a few answers here. We'll start, of course, with Dr. DiMuzio's question, where he asked about your technique. It's 10 milligrams and you're waiting 10 minutes, but you're ballooning before you do the power pulse. Can you talk a little bit about that?
Okay, so Dr. DiMuzio is correct. Thank you, Dr. Parikh, for going over the paper. You did a great job and pointed out some of the highlights. I'm going to try to emphasize some of the reasons why we did this protocol and some of our learning curve along the way, because it was a work in progress over a number of years. And as you pointed out, at this point in time, we didn't have IVUS at this institution. So no, we don't use 10 milligrams on every patient. 10 milligrams is for a femoral popliteal, iliac, all the way up. If it's a short isolated segment, just say an iliac vein stent that went down and the femoral popliteal is still open, then I would use much less, because I don't think you need to put 10 milligrams into a very short segment. Yes, in general, we like to wait 10 minutes, but sometimes we don't, all of us have enough patience to wait 10 minutes before we can start grabbing the balloon and going to the next step. So sometimes, yes, it was a little bit shorter. In general, by the time we actually got to doing the suction thrombectomy, doing the balloon maceration after the TPA power pulse, and doing the suction thrombectomy after the balloon maceration, we were already pushing 20 minutes. So Dr. Tamuzio's question about the timing is correct, that it's not just a one step where you do the balloon maceration, the TPA power pulse, the balloon maceration, followed by the suction thrombectomy. It's a process that ends up taking at least a half an hour on the first go around to try to clean up all the clots. The key to this procedure is combining the standard rheologic power pulse TPA with the balloon maceration, because you really do break up these clots, this subacute clot, and into smaller pieces, and it lyses much faster than what we were doing before then. And that's what really is the key to this technique. It's a little bit different than what we were doing beforehand. We found that we were able to reduce the amount of, not only go down to one session in 80% of the cases, but our total TPA usage also went down. Of course, our ICU usage was knocked down to almost 80%. So all of those were key components, but the balloon maceration is the heart of this. And that's combining techniques that were described before into one procedure, and we called it fast track. So getting back to Dr. Tamuzio's questions, no, 10 milligrams isn't used for everybody. Sometimes it's as low as 4, sometimes it's up to 6, depending on the length and the degree. Some other people were asking questions about the duration. If it was more than 2 weeks, we didn't have good results trying this type of procedure. If there's some subacute or chronicity associated with this, we would probably not be doing these types of procedures, or would be not as enthusiastic, just because our results have not been as good. Dr. Harris points out that the use of IVUS is key to identifying these, and I agree with that. Having said that, in a prior paper, we also looked at IVUS-based findings as compared to venography, and how do you correlate the two? What signs can you look for on venography saying that there's still a hemodynamically significant lesion that you may not see so easily? Bullseye may be one way that we explored before in a prior paper in the JVS BNL a couple of years ago. Another is that one thing that we described during this paper was using the balloon itself as you inflate only to 4 to 6 atmospheres. You can use the contour of the balloon, the wasting, to identify lesions that are subacute, chronic, or fibrotic lesions that need to be stented. So there are a couple of ways to, even if you don't have IVUS, especially in other countries where it may not be as accessible because of its cost, there might be some utility using venography in combination with the bullseye signs, in combination with balloon contouring to identify these lesions, and still end up with fairly good results.
Ruth, you had a couple questions. We brought you here for a reason. No need to be silent.
Well, I wasn't sure, and my little dog has decided she wanted to be a part of this. So I'll just ask my questions to Dr. Hingorani. So, you call this fast track thrombolysis. It's really aggressive thrombolysis in very selected patients. So I want you to you did talk a little bit about the selection of the patients, but you had really good success rates, which I don't think have been mirrored in other series. So number one, how did you define the age of the clot? What was going to be someone you were going to put in this aggressive therapy? Was it 2 weeks? Was it 2 weeks from presentation? Was it 2 weeks from when they thought their symptoms came on? And how did you define clearance? There is in your methods, you talk about patients with complete or near complete resolution. What does that mean? Is that 50%, 75%? How did you define resolution? And I think those are my main questions for you. And then you talk about what you put them on in terms of post-procedure anticoagulation. Did you put these folks in stockings as well? Did you have any hematuria or need transfusions? There's my questions.
Excellent questions and very important. So one of the reasons why we wanted to speed up the procedures is because we had some catastrophic results using TPA and with catheter drip overnight, which is a reason why we want to become aggressive and try to limit the amount of exposure that these patients had to TPA overnight with the catheter drips that they had in the ICU. In general, if the patient's symptoms are less than 2 weeks upon presentation, they're immediately taken up to the interventional suite. So it's symptoms that we're looking for. If they were more than 2 weeks, we weren't as enthusiastic because, as you know, the results have not been so good. If there's still more than 30% residual stenosis after this extensive aggressive balloon angioplasty and stenting, I think you probably need to consider leaving the patients on a catheter drip associated overnight for the fear of rethrombosis of these patients. In this series, we had somewhat limited, fairly local lesions, thrombosis mostly in the iliac veins. We've since expanded this to patients who have thrombosed all the way down to the tibials, common iliac all the way down. And our results are fairly good. Although, as Dr. Demuzio said, then we're really using 10 milligrams and we're really waiting at least 20 minutes for these. So I think you do need to tailor this to the degree of thrombosis that you have. In general, we've been very, very happy with these results. We have not had much hematuria with these, fortunately. We did have that one retroperitoneal hematoma, and we haven't had any transfusions, knock on wood, so far with these, with this type of procedure. We have used this also in the arterial side, this type of aggressive angioplasty and primary stenting. And we see when we compared it to our historical controls, we were able to reduce the amount of TPA that we're using. We were able to reduce the cost because the TPA is out of the picture and the ICU usage. So we do think that for certain patients, if you can decrease the TPA usage by a half or a third in some cases, and keep the patients out of the ICU and send them home within 24 hours, it's hard to beat. There are, of course, new technologies that have come out since this paper, which this paper started in 2014, with other catheters and other techniques with removal of clots. The Inari system, for example, and some of the other systems that are out that say that they can also remove the clot in one shot. And I think we're starting to get enough tools in this space that we can actually start to compare them and see which patients do better with which techniques. So I think this is an opportunity to look at the angiojet system that we used in this series, the Inari system, and some of the other systems that are being developed with, let's say, stent thrombectomy or such, and say which patients do better with which procedures. I don't think we're there yet in the literature. We are fortunate that we have all three of them in the hospital available, but we don't have a lot of them, and we don't have a lot of comparison data yet. So I think that's where we're going to be heading for the future.
Anil, before we move on to the next paper, I just wanted to know if you could address Dr. Wakefield and Dr. Glavicsi's kind of comments together, which are about the stents. You know, about half of these patients are stented. It's really not an iliofemoral DVT. You know, did you have to restent some of these patients, and how are you choosing which who to stent?
So the stenting was based upon residual stenosis, quite frankly. At this point in time at this institution, we only had the wall stent. So this paper is only about wall stent. So again, if there's more than 30% residual stenosis after you do all this aggressive angioplasty, then we went ahead and stented any lesions in the iliofemoral segments down to the common femoral vein for the fear of closing everything.
Well, thank you. I think that was great presentation and really generated a lot of good discussion. So we're going to move on to our next paper, see if we can keep this ball rolling. Dr. Bonakowski.
Misty, while Ann is switching over, Peter, maybe you could talk about that new guidelines. The ATTRACT trial kind of maybe diminished our enthusiasm about this.
Just a minute of summary. Actually, I summarized my opinion about the European guidelines in an editorial in the February issue. The guidelines came out in June, and first time it recommended with a high level of evidence based on the sub-analysis of the ATTRACT and based on a new meta-analysis that in select patients, iliofemoral thrombosis should be treated with catheter-directed thrombolysis. And this is a very important landmark because of the chest guidelines that in our country completely neglected to recommend catheter-directed thrombolysis. So I think all of you should read the guidelines, and if you want to read the editorial that's in the February issue.
Good evening. Can everyone hear me?
Yes.
All right. I want to thank Dr. Humphreys and Dr. DiMuzio, as well as the JVS editorial board for this opportunity to present. I'm Anna Bonakowski. I'm one of the new faculty at Maine Medical Center, and I have the privilege of introducing this great paper that was written by some of the best mentors I had during residency, who I miss dearly. And this paper is entitled The Effect of Concomitant Deep Venous Reflux on Truncal Endovenous Ablation Outcomes in the Vascular Quality Initiative. Chronic venous insufficiency is prevalent. Up to 30% of the population suffers from this entity, and up to about 1% is affected by venous ulceration. This has a huge impact on patients' quality of life with significant pain, swelling, and interference with the ability to work and sustain employment. It is also extremely costly, as the economic burden of medical expenditures associated with this venous insufficiency is estimated to be up to about $1 billion annually in just the US alone. The good news is that we do have effective treatment options available for those who fail conservative management with compression and elevation. The studies that have evaluated patient outcomes after treatment of superficial venous ablation typically stratify patients by the clinical class of the SEEP classification and primarily focus on scoring systems like the Venous Clinical Severity Score, or the VCSS, to measure clinical improvement. I know there are a couple of general surgery and some younger residents on, so I just wanted to show this since we use and discuss these are discussed in the paper. So just to briefly introduce, this slide shows the clinical class of the SEEP classification. And you can see as the C class increases from 1 to 6, this patients manifest a more severe disease, with C5 and C6 being healed and current active ulceration. And then the VCSS is a measure of 10 categories to help assess clinical outcomes by looking at the change or improvement of the score after intervention. The categories you can see in the red box, they include details such as the pain, varicose veins, edema, skin changes, and more details about the ulcer, in addition to whether the patient can demonstrate compliance with compression. But here's the challenge for management of venous disease is that there's limited data on patient outcomes and quality of life after ablation in those who have both superficial and deep venous reflux. And this makes it difficult to counsel our patients who have both deep and superficial reflux on expectations after ablation. But concomitant deep and superficial reflux is common, and up to about 48% of patients have both. And it's been suggested that the treatment of superficial reflux could actually improve the deep reflux in about 30% of patients. But this means that 70% of patients likely deep reflux may remain unchanged. So the authors of this paper set out to investigate patient-reported outcomes as well as the clinical outcomes and complications in this patient population with deep and superficial reflux. So with that, I would like to introduce Dr. Arthi Minasandram. She is our vascular surgery PGY1 at Maine Medical Center. She graduated from Tufts Medical School last year, and along with her MD, she also has a master's in teaching and a master's in biomedical sciences. So without further ado, I'll turn things over to her, who she will discuss the details of this paper.
Thanks, Dr. Bonikowski. Can everyone hear me okay? Great.
Yes.
I would like to thank Dr. Humphreys and Dr. DiMuzio for the opportunity to present today. I would also like to thank the editorial board of the JVS for their hard work. So the study the authors had two hypotheses going in. First, patients with concomitant deep vein reflux would have worse patient-reported outcomes compared to patients who only had superficial venous reflux after superficial venous ablation. Second, patients with concomitant deep vein reflux would have higher complication rates after truncal venous ablation. For those of you who are not familiar, truncal venous ablation is ablation of the great saphenous vein and the small saphenous vein. The study was a multi-center retrospective cohort study of 4,881 patients over 5 years. For this study, the authors looked at the VQI varicose vein registry database from 2015 to 2019, which is the earliest prospectively entered data into that data set. The patients included in this study were patients who underwent lower extremity truncal ablation for superficial venous insufficiency, including only radiofrequency and laser ablation. Patients receiving other procedures were excluded from the analysis. This included sclerotherapy, phlebectomy, or concurrent treatment of veins other than the truncal veins. The authors did a separate multivariate analysis, including patients who also went sclerotherapy and phlebectomy for a sensitivity analysis, which is included in the supplemental figures. The data was analyzed using the clinical classifications pre and post-operatively using the C class of the SEEP classification, the Venous Clinical Severity Score pre and post-ablation, patient-reported outcomes based on a survey pre and post-ablation, and post-operative complications. Statistical analysis was done with t-test, chi-squared analysis, and multivariate logistic regression for covariates to evaluate for confounders. The patient-reported outcome survey is unique to this study, as prior studies have not looked at patient-reported perception of improvement or lack thereof after their procedures. The authors used the previously validated HOSTI instrument delineated in the first 5 rows here and added appearance and effect on work and activity to the evaluation. Each of these 7 characteristics was evaluated on a scale of 0 to 5, except for appearance, which was evaluated from 0 to 4, creating a highest possible total of 34. Here is a table of the patient characteristics between the two groups. The statistically significant differences between the two groups are highlighted in yellow here. Patients without deep reflux were more likely to be female, not be white, and have longer length of follow-up. They were also more likely to receive anticoagulation and be compliant with compression therapy. Figure 1 demonstrates the distribution of patients between amongst C classifications is similar between the two groups pre and post-procedurally. Patients with deep reflux, shown in the gray columns, were more likely to be in the extremes of the C classification, highlighted in the red boxes here. In figure 2, the patient-reported outcome survey labeled here as the total symptom score and the venous clinical severity scores are presented for the two groups as comparisons for pre-procedural, post-procedural, and the difference. Starting with figure A, the pre and post-procedural patient-reported symptom scores are significantly lower for patients with deep reflux compared to no deep reflux, but the reported change in patient-perceived outcomes after ablation was not significantly different between the two groups. Figure B also shows that the venous clinical severity scores for patients in the deep reflux group were lower than for the patients with no deep reflux group, both pre and post-operatively, but the patients with deep reflux had significantly greater improvement after ablation. Notably, for each statistically significant finding in this figure, the difference was within 1 point out of 34 for the total symptom score and 27 for VCSS, so the authors questioned the clinical significance of this finding. The authors also did a multivariate regression analysis to evaluate for confounders, and found less VCSS improvement in patients who had procedures in 2019, a higher clinical calcification, specifically C6, and more compliance with compression therapy. After controlling for confounders, there was no significant difference in improvement in VCSS between the two groups. Systemic complications such as allergies, MI, CVA, TIA, and PE were exceedingly rare, 6 for the entire group, which was about 0.1%. The statistically significant procedural complication rates, as you can see here, are paresthesia, pigmentation, superficial phlebitis, wound infection, and proximal thrombus extension. The authors hypothesized that the increased wound and skin complications for patients with deep vein reflux are because of complications related to increased swelling related to distorted lymphatic flow, also known as phlebolymphedema. The most prevalent and most concerning complication was the proximal thrombus extension, also known as endovenous heat-induced thrombosis, or EHIT, which was 3 times as likely for patients with deep reflux compared to superficial only. Overall, there was a 10% complication rate for patients with concomitant deep venous reflux versus 3% for no deep venous reflux. The limitations of this study include ones inherent to the VVR, which only captures patients who received procedures. The database also does not record location of reflux, so the authors were unable to evaluate whether location had any bearing on complication rates. It also does not capture deep venous reflux solution after ablation. Also, patients with more severe disease are quite possibly overrepresented in the VQI in general compared to the generalized population. Ultimately, contrary to their initial hypothesis, the authors found no clinical significant difference in improvement after ablation for patients with concomitant deep reflux versus superficial only. Compression stocking use might be a good alternative to intervention, since increased compression stocking compliance led to less perceived clinical improvement after ablation. In conjunction with their second hypothesis, the authors found more postoperative complications in patients with deep venous reflux, most notably a 3-fold increase in endovenous heat-induced thrombosis, or EHIT. Therefore, they recommended counseling patients with deep venous reflux on the 10% possibility of complications when offering ablation therapy. I'll open up for discussion.
Thank you for that. Dr. Brown, do you want to start us off?
Yeah, it was a wonderful presentation. Thanks for picking the paper. And I think that I'm grateful that Dr. Wakefield's here with me. Dr. Hankey had to sign on to another call, and Dr. Osborne, I think, is in the operating room. So I'm happy to take whatever questions I can. I think that this paper was really eye-opening for us as a group. I think it started out with a very solid hypothesis that we thought was very theoretically founded, and it turned out to be exactly opposite of what we found, which is always kind of an interesting thing from a research perspective. So,
has it changed some of your thoughts on management? And Dr. Bush will ask you a couple of questions as well.
I'm a 5th-year general surgery resident, so my actual venous disease treatment experience is limited to being in the operating room with Dr. Wakefield as an intern. So it hasn't changed my approach to venous patients, but Dr. Wakefield, I'm sure, has some interesting thoughts.
Thank you. I've always tried to be very conservative with people when they have underlying deep vein insufficiency or deep vein reflux, because I tell them that they've got to be in compression for that reason. And so even if I do something on the superficial system, it doesn't change the fact that I'm going to want them to stay in a good vein health program, including compression. So, if somebody has very symptomatic varicosities and you're doing it for that reason, that's something that may be acceptable. But in general, I try not to do a lot of the superficial procedures when they have deep vein reflux. And the one problem, or there's many limitations with a registry study. One of the limitations is not knowing exactly where the level of deep vein reflux is. There has been one really interesting paper that I can think of that Bill Marston did once, where he showed that if the patient had popliteal reflux, if you measured the velocity of reverse blood flow, the higher the velocity, the worse the patient did, or the less benefit they would get from the superficial procedure. And so that sort of goes along with the idea that it would be very interesting to take this data and try to do a study where you actually try to look at and see whether if the patient has axial deep vein reflux versus isolated deep vein reflux, if the popliteal valve is involved or is not involved, if that would change your results, for example. But we don't have that granularity in the VVR.
Dr. Bush?
Thank you both for presenting. So I practice a little bit differently than Dr. Wakefield. If someone does not have a deep venous thrombosis and they have both superficial and deep venous reflux, my thinking is that if I take the superficial reflux out of the equation, that the hemodynamics of the leg will be better. That being said, similar to what Dr. Wakefield said, there is some data showing that, and some reports that if someone has isolated common femoral vein deep venous reflux, that's going to get recorded as deep venous reflux. However, it's isolated common femoral vein reflux, and that if you ablate the saphenous vein, the great saphenous vein, that'll resolve because it's really probably from the saphenofemoral junction. That being said, my question is to Dr. Wakefield, and it can be to Dr. Brown, is that should we add something in the VQI to show, is it just isolated common femoral vein? Is it isolated, or is it diffuse venous reflux? Because those patients will need, if it's diffuse, they're going to need compression for the remainder of their life. And then my other question is on patients with deep venous reflux. Yeah, I'm sort of a scaredy cat, and I think sometimes we practice anecdote-based medicine as opposed to evidence-based medicine. And my patients get a small shot of fragment or Lovenox prior to venous ablation procedures. It's probably treating me and not them. However, in patients who have deep venous reflux, should it be part of the procedure in those patients given the results of this study? Thank you.
Thanks, Ruth. I'll answer, and then Craig, if you want to answer also, please do. I like your idea. I think if we had more granularity in the VVR, especially on the level of deep vein reflux, that could answer the question that this study sort of brings to bear. I would support that. I know Nick Osborne is now the head of the VVR from a physician perspective, and I'll mention that to him, and that might be something for the committee to take up and try to add in. As far as I with all my venous procedures, especially because I tend to be operating on people who have very significant venous reflux and very large varicosities, I always give a shot of heparin on the table, and then I use the Caprini risk assessment tool. And if patients have a Caprini risk score of 8 or greater, I usually will give 1 week of postoperative Lovenox, or now starting to use prophylactic DOAC. And we've been tracking our data for many, many, many years, and we're down to a DVT rate for patients who have very significant varicosities and reflux, less than 1.5%, using that way of doing things. So I am concerned always about thrombosis. Now, that is not necessarily going to prevent the EHIT, however, because I don't think EHIT is the same thing. And so I don't know how to explain the EHIT results that we're seeing here in the registry. And the other thing is we don't know what level of EHIT this is. Is this EHIT 1 or 2 that you don't necessarily have to treat? Or were these EHIT 3s or 4, based on the new guidelines for EHIT? I guess more granularity would be helpful with that too.
Yeah, I don't have a whole lot to add. I think I agree in terms of, in my opinion, this seems like exactly what we should do with these quality improvement registries. So we do an analysis, we identify a problem, and we pivot in terms of what we need to collect to answer the next question, which in this case is exactly that, the question about location of reflux in the deep venous system. I think if we can find a way to sneak in peri-procedural anticoagulation, those types of questions are all answerable with a registry. And I think that it's one example of the power of using these sort of quality improvement collaboratives. So I think that My big takeaway from using the VVR, really, we've now published, I think, 3 papers out of this database, and it is, the VQI as a whole is really a phenomenal registry. I've done a lot of registry work, and this is, the VQI is phenomenal. The VVR in particular is extraordinary in terms of the level of detail that we have with respect to treated veins and locations and all that sort of stuff. So I think that there's a real opportunity there that I think it'd be really awesome to capitalize on here. I'll try to answer Dr. Aronson's question about uniform criteria for EHIT. No is the short answer. So the preoperative assessment is requires an ultrasound, obviously, for the diagnosis of deep reflux or superficial reflux. There is no standardized postoperative assessment from an ultrasound perspective, and so it is one of the big limitations of the VVR is that there's not a standardized surveillance for any sort of ultrasound assessment. So we don't know, if you don't go looking for a DVT, you won't see it. And I think that that's a big limitation here. The benefit is that at least with respect to EHIT, it has really the only possibility of biasing our results towards the null hypothesis as opposed to the other way. So if anything, we're underestimating the contribution of deep reflux to EHIT rather than overestimating. But your point is well taken. I think that it's a limitation of the VVR that would be nice to address. Go ahead.
So Craig, can I just follow up to your comment there?
Sure.
Just say though that as the VVR data becomes available to practitioners, only if the patient has had an ultrasound within the first 2 weeks can a DVT rate or an EHIT rate be given back to the practitioner, because of exactly that question. If you don't do an ultrasound in the first 2 to 4 weeks, and you only do one at 3 months, and you don't have any thrombotic complications that you see, you can't report a rate of 0% because you didn't look for it. So you have to have an ultrasound within the first 2 weeks. That's what the rules of the VVR.
And to Dr. DiMuzio's question, the teasing out the effect of compression therapy, I think, is really tough with this data set. The variable that we included in our multivariable model was actually post-procedural compliance, but there's essentially direct collinearity between pre-procedural compliance, and that you can imagine that patients who are compliant with pre-procedural therapy are essentially the same exact patients who are post-procedurally compliant. So it's really not possible for us to tease out the contribution of those. It may be, in fact, that pre-procedural compression therapy has an opposite effect as post-procedural therapy, and there's no way for us to know that. So I would caution anybody from taking the compression therapy findings here as causal. They're probably related to confounding and patient selection, and we include them in the multivariable model to try to address that. But I think that it would be wrong to take them as a causal effect here. So I would caution people from doing that.
And there was one last question just asking about, do you find that your EHIT rate increases for patients with previous DVT and subsequent deep venous insufficiency? And therefore, are you more likely to anticoagulate those patients post-procedure? And you kind of touched on that a little bit. I don't know if you want to expand on it at all.
I really do go based on the Caprini risk assessment and the tool, and that's what we use. I do think if the patient has a significant thrombotic history, they will end up most likely getting a week of post-op anticoagulation. If I have somebody who has significant superficial thrombophlebitis, especially if it just came out of the blue and I'm operating on the patient, I will, in their history, I will also include them. And one of the reasons for that, as far as giving them a week of post-op anticoagulation, because we used the 2005 Caprini risk assessment tool, which was the original risk assessment tool. And that's the one that we've used now, for the last 15 years. And I don't necessarily want to change that. But the phlebitis is not in that tool. The phlebitis was added in the further revisions of the tool. And there is actually now, through the American Venous Forum, a committee that has been formed in order to try to update the Caprini score, including many things that have been learned in the past 15 years since it first came out, in order to be able to make it more up to date, and at the same time not lose the ability to compare data that you might generate today with data from 10, 15, 20 years ago. And phlebitis, for example, will be one of the things that will be added into the revised Caprini that eventually comes out, for example. So if the patient has a history of DVT, significant DVT, or if they've had a history of phlebitis, I tend to give them, a week of postoperative anticoagulation prophylaxis. If their score is 6 or 7, not 8, but if they have that in addition, sometimes I'll do that.
Before,
I think we have a wrap.
can I ask you, Tom, if
Yeah.
you changed your mind, and do you operate now on patients with deep vein reflux easier? Because your paper showed that every second patient has a deep vein reflux, and actually the results are better than in patients who don't have deep vein reflux. So I think this paper is revolutionary. We should operate on everybody with deep vein.
Well, Peter, you could look at it the other way and say that we didn't find that your results are worse. And in fact, the finding that the results are equivalent, although the VCSS score was a little bit better when you looked at all the variables, it wasn't significant anymore, but it wasn't worse. And so it does give you the idea that if somebody does have deep vein reflux and they have significant superficial reflux and they have failed a conservative trial, as long as the patient knows that, in fact, by taking care of the superficial system, you still are going to want them to stay in compression and a good venous health program for the deep vein reflux, then, if you feel that you're not going to be hurting them necessarily by operating on them. And also the patient who has deep vein reflux and has symptomatic varicosities, you feel better about the fact that you can operate on them and not hurt them by doing that. Again, it hasn't really changed a lot of the way I have practiced over the years. It sort of validates that I should be conservative, but when you feel like the patient hasn't responded enough, that you can then go ahead and feel comfortable doing it. Does that make sense?
Yeah, it does. The other take-home message is that EHIT has to be looked at it differently than the way we are looking now. EHIT 1 is not a complication.
Right.
I mean, if you break down and you only take EHIT 3 and 4 that needs treatment, then your results change, because the big difference in complications, quote unquote, are maybe EHIT 1 or maybe 2 that really is not important.
Yeah, for sure. So Peter, the one thing I thought about from this paper, thinking about the future is, for all the years that we've had the registry and years before that, we have always scanned everybody 1 week. That's sort of been our MO. And I've been thinking for the last number of years that there are patients who just have an ablation, don't have a flebectomy, for example, who don't necessarily need to be scanned at 1 week. And so you could use this paper to say, if the patient has reflux and you're doing work, perhaps you should scan them at 1 week. And if they don't have reflux and you're just doing an ablation, if their EHIT rate is less than 1%, you probably don't have to scan them at 1 week. We're actually talking about trying to look at that through another registry study to try to come up with an answer about that in one way or another.
All right, I want to thank our new friends from the Carolinas and the Maine Medical Centers for participating. Great jobs, faculty, super great jobs to our young presenters, and also for the authors joining us, and Dr. Bush and Dr. Glavitsky from the JVS, and all the participants. And we will see you in April. And thanks again. And Misty, thank you. And have a great night, everybody.
Thank you very much.
Have a good night.
Bye.
Bye-bye.
Bye-bye, Anna.
You know, Paul, this new update of the e-heat to me was a disappointment because the E1 has a complication.
I saw that but did not read it. You're saying that they classified stuff that doesn't even, it just barely touches the deep vein as a complication?
One means that the saphenous is occluded up to the saphenofemoral junction. I mean,
Yeah.
so,
Just repeat the ultrasound in a week and make sure we stand them up, and oftentimes it retracts, and really depends on how good your ultrasonographer is.
well,
Thank you again for joining, and I look forward to chatting with you soon.
I sent you that editorial.
Oh, perfect. I'll put that out with the, we'll post it with the recording as well.
Okay, thanks.
Have a good night.